Welcome to the Deep Dive. Today, we're plunging into something pretty amazing, actually. How just a tiny fluid sample from a horse's chest
Yeah.
can unlock some really vital clues about its health. We're talking equine fluid analysis and the procedure to get it, thoracocentesis.
Exactly.
And this isn't just for the vets listening in. It's really a fascinating look at, diagnostic detective work.
It really is. This deep dive, it's going to shed light on just how critical this analysis is for diagnosing and managing all sorts of conditions in a horse's chest. You're going to see how vets figure out the reasons behind fluid buildup, that's pleural effusion, and why getting those details right is just crucial for the horse.
Right.
And the sources we've pulled together, think of them as your blueprint for today, a way to get quickly up to speed on this really vital area.
Okay, great. So let's start right at the beginning. What is normal pleural fluid in a horse? What's it even doing there?
Okay, so normally pleural fluid is what we call a dialysate of the plasma.
How do I say?
Yeah, think of it like a super filtered fluid. It's constantly being made and sort of recycled. There's usually just a tiny amount in the pleural cavity.
That space around the lungs, right?
Exactly, that thin space.
Ah.
And it's drained away by the lymphatic vessels. Now, an effusion just means there's more of that fluid than usual.
Okay, there's too much fluid.
Right. And what that extra fluid looks like, its character, tells you what kicked things off. It could be inflammation, maybe a tumor, problems with protein levels, or even bleeding inside.
Wow.
And it can stem from issues in different body systems, respiratory, obviously, but also cardiovascular, lymphatic, even the liver sometimes.
So if a horse does have an effusion, what might you, the listener, actually see? What are those telltale signs?
Well, the signs can vary quite a bit. You might see signs of pain, like pawing the ground, or the horse just doesn't want to move.
Reluctance.
Yeah. Or a stiff gait, maybe holding their elbows out sort of away from the body. We call that abducted elbows.
Okay.
Rapid breathing, tachypnea, or difficulty breathing, dyspnea. Those are pretty common too.
Right, breathing changes.
Definitely. And a vet might listen and hear no lung sounds down low in the chest. You might also see swelling, edema on the chest or underneath.
Sternal or ventral edema.
And then there are the more general signs, seeming depressed, weight loss, maybe a fever, a cough, nasal discharge, can't exercise like they used to.
So it can look like a lot of different things, potentially.
It can. And it's important to remember this can hit any breed, any age, any sex. It's not specific.
Okay, so a horse is showing some of these signs. Things aren't looking right. How do vets go from thinking, maybe pleural effusion, to actually getting proof? How do they get that fluid sample?
Right, that's where thoracocentesis comes in. That's the procedure, the tap, specifically to collect that pleural fluid for analysis.
And you do it when you suspect an effusion.
Exactly. When there's evidence, maybe from the physical exam or from x-rays or very commonly ultrasound.
Okay, so walk us through it. How does it actually happen?
Well, first, the horse is almost always sedated. You need them calm and still. Then the vet finds the spot. Ultrasound is really helpful here to, pinpoint the fluid pocket and make sure you avoid hitting anything vital.
Like the lungs or heart.
Precisely. Usually it's the 7th or 8th intercostal space, so between the 7th and 8th ribs.
Got it.
Then that area gets clipped, scrubbed surgically, super clean. Local anesthetic goes in to numb it up. A tiny nick is made in the skin, just helps the needle go in smoother. And then the cannula or needle is carefully inserted into that pleural space.
Carefully being the key word.
Absolutely. You have to avoid the back edge of the rib, the caudal margin, because major blood vessels and nerves run right there.
Okay. Critical point.
Very critical. Once you're in, you gently aspirate the fluid. You collect it aseptically, clean technique into a sterile tube for bacterial culture.
To see if bugs are growing.
Right. And into an EDTA tube, that purple top tube which stops clotting and preserves the cells for the cell counts, the cytology, looking at the cells themselves and measuring the protein.
That sounds pretty involved. Are there risks? Things that can go wrong with the tap itself?
Yes, there are potential complications, like with any invasive procedure. Locally, right at the site, you could get some bleeding, cellulitis, which is a skin infection, maybe some trapped air under the skin called emphysema, or even an abscess.
Okay, at the site. What about more generally?
More generally, though less common with good technique, you could see epistaxis, a nosebleed, or the big concern is pneumothorax.
Air in the chest cavity.
Exactly. If air gets sucked into the chest, it can collapse the lung. So technique is key to minimize these risks.
Okay, so you've got the fluid, you've avoided the major pitfalls. Now the real detective work starts.
Yeah.
How do you read that fluid? What's normal versus abnormal?
Right. This is where it gets really interesting. Normal pleural fluid. It's pretty distinctive, usually straw-colored or maybe light yellow. It's clear. Odorless.
Okay.
And there's not much of it, usually less than 100 mils. Protein is low, under 3 grams per deciliter. Sometimes even lower benchmarks are used.
And the cells?
Cell count is also low. Less than 10,000 nucleated cells per microliter. And those cells are mostly healthy-looking neutrophils and mononuclear cells, things like mesothelial cells from the lining and macrophages.
So pretty clean stuff normally.
Yeah, you might see a few red blood cells, but that's usually just from the needle poke itself, not a sign of internal bleeding.
Gotcha. So what does abnormal look like?
Well, that's where the clues really are. Just looking at it grossly, abnormal fluid is often discolored, maybe reddish or cloudy, turbid. That cloudiness points to more cells and more protein.
Okay.
You might even see fibrin clots floating in it. And a really key sign of foul odor that strongly suggests anaerobic bacteria are involved.
Oof, yeah. Bad smell, bad news often.
Often, yes. So, for example, if the fluid is septic, usually from bacterial pleural pneumonia.
Infection spreading from the lungs.
Exactly. You'll see a high cell count, way over that 10,000 mark. And crucially, you'll see degenerate neutrophils.
Degenerate, meaning?
Well, meaning they look damaged, stressed out, basically falling apart as they fight the infection. It's a huge red flag for bacteria.
Okay.
The fluid's cloudy, maybe has clots, might have that foul smell, and the lab values back it up. High protein, over 3 GDL, and low glucose. The bacteria are eating it.
Ah, okay.
High lactate and low pH also point towards bacterial infection. Sometimes you can even see bacteria inside the neutrophils.
Wow.
So, yeah, a culture is definitely needed then. And if it's been going on a while, chronic inflammation, you start to see more of those large mononuclear cells, and they might look like they're actively cleaning things up, phagocytic.
So that's septic fluid, but you said the character tells the story. What are other stories the fluid might tell? Different kinds of abnormal.
Exactly. It's not just about infection. You could have something like a chylous effusion.
Chylous?
Yeah, it looks milky or cloudy, but it's not usually infection. It's characterized by lots of normal-looking lymphocytes. It means lymphatic fluid, or chyle, is leaking into the chest. We measure triglycerides and cholesterol in the fluid to confirm that one.
Okay, totally different cause then.
Totally different. Then there's neoplastic effusion. That means cancer.
Oh, wow.
You might actually find neoplastic cancerous cells floating in the fluid. The fluid itself might be watery and blood-tinged, serosanguinous. Lymphoma is a common one,
Right.
where you see these large abnormal lymphocytes. But other tumors can shed cells too, like mesothelioma or metastatic cancers that have spread there.
So you're literally looking for cancer cells?
Sometimes, yes. Then there's hemorrhage. Now, most minor blood contamination is just from the tap, iatrogenic.
Right, the poke.
But if there was significant bleeding before the sample was taken, you'll see evidence of red blood cell breakdown, like pigments or macrophages that have eaten red cells.
Okay.
And you can even get fluid buildup just because of low protein in the blood hypoalbuminemia.
How does that work?
Well, protein in the blood helps hold fluid inside the blood vessels, right? It provides oncotic pressure. If protein is low, that pressure drops, and fluid can just leak out into spaces like the chest. That fluid, a transudate, might actually look pretty normal cytologically, just there's too much of it.
Fascinating. Almost like a plumbing issue.
Kind of, yeah. And similarly, increased hydrostatic pressure, like from congestive heart failure, can push fluid out too. Those effusions tend to have a bit higher cell counts and protein than a pure transudate, but the cells often look normal.
So many possibilities. Are there other tests done on the fluid itself?
Oh, yes. Besides looking at the cells, we always do a total protein measurement. That cell count and differential we talked about, bacterial culture and sensitivity, is key if infection is suspected.
To know which antibiotics to use.
Exactly. And a gram stain can give a quick clue, are we dealing with gram-positive or gram-negative bacteria, even before the culture results are back. Helps guide initial treatment.
Okay, so you have all these clues from the fluid itself.
Yeah.
The color, the cells, the protein, maybe bacteria. How does this all come together? How does the vet use this to help the horse?
Right. It's about putting all the puzzle pieces together. The fluid analysis is huge, but it's part of the bigger picture. It helps narrow down that list of potential causes we touched on.
Like the pleural pneumonia, the cancer, heart failure.
Exactly. Pleural pneumonia, neoplasia lymphoma, SCC, adenocarcinoma, mesothelioma, congestive heart failure, hemorrhage from trauma, chylothorax, even rarer things like parasites, ruptured abscesses, foreign bodies, just primary inflammation of the pleura, or that low protein state, hypoalbuminemia.
It's a long list.
It is. And other tools are vital too. We mentioned ultrasound essential for finding the fluid and guiding the tap safely.
Right.
And chest x-rays, thoracic radiographs are really important after you drain the fluid so you can actually see the lungs properly and look for lesions there.
Because the fluid hides things on the X-ray.
Precisely. And sometimes other procedures, like sampling fluid from the trachea, a tracheal wash or aspirate, can help diagnose things like pneumonia or even some tumors.
It really sounds like a comprehensive investigation.
It has to be.
So this deep dive really shows how critical understanding this fluid analysis is, getting that diagnosis right, and doing it quickly based on what the fluid tells you. It makes a huge difference for the horse's prognosis, doesn't it?
Absolutely. It underlines how that detailed knowledge, that specific information from the fluid, directly impacts the outcome.
What an incredible deep dive. It really is amazing thinking about how that small sample holds so many potential answers, guiding vets to figure out what's wrong. It just reinforces how valuable this kind of details look is, getting beyond just the surface.
It really does, and maybe something for you, the listener, to think about. This whole intricate process, analyzing this tiny bit of fluid to understand a much bigger problem in the horse. Doesn't that mirror detective work in so many other areas? Think about your own field, your own interests. What seemingly small details might be holding the key to a bigger understanding or, a critical insight if you just knew how to look for them and interpret them? This dive into equine diagnostics really just underscores the power of paying meticulous attention to detail.